Susan Paddock is Chief Scientist and Executive Vice President at NORC at the University of Chicago. Her team at NORC includes statisticians, survey methodologists, data scientists, quantitative social scientists, and AI researchers who are engaged in projects for federal, other governmental, and private sector clients on topics that span multiple substantive research areas, including education, health, global, and public affairs. Susan has published methodological development in the areas of Bayesian method, causal inference, hierarchical modeling, longitudinal data analysis, and missing data techniques. She served on editorial boards for several journals, including Annals of Applied Statistics, JASA, and Harvard Data Science Review. She is a fellow of the American Statistical Association and was the recipient of the 2013 Mid-Career Award of the Health Policy Statistics Sessions of the American Statistical Association. She is the 2024-2026 Vice President of the American Statistical Association. She received her PhD from Duke University and BA from University of Minnesota. So welcome and thank you, Susan, for coming. And I would like to say one thing for one logistical thing before I give the floor to Susan. We ask that for questions that you put them in the Q&A section because they're easier to find than in the chat. So please put any questions in the Q&A section, and Susan will post periodically to answer questions. Okay, Susan, thanks again, and the floor is yours.
Great. Well, thank you so much, Carolina, for that introduction, and thank you for inviting me to be part of this webinar series. I am really honored, and I'm honored that so many of you are joining today. So I want to first acknowledge that the vast majority of what I'll present either comes from or is inspired by a paper that Carolina and I recently co-authored with Jay Bright and Brenda Betancourt on statistical data integration for health policy evidence building. And it was a real pleasure to work with them. And this paper is, I'm told, within a week or so, it will be posted as early online access at the annual reviews of statistics and its applications. And so please stay tuned for that. I put the link on this slide. And with that, if there are any errors or omissions in this talk, I take full responsibility for those. And here's an overview of what I'll present today. And data integration is a very big and expansive topic. So I'm approaching this from the perspective of providing an introduction and an overview to the topic, and in particular focusing on health policy, where there are a lot of applications for data integration. It's one area of many, of course, where there are really rich data sources with different kinds of information we might want to pull together to improve our ability to make decisions and build evidence. And so I'll start by motivating the topic, and secondly, I will discuss data quality because that's a huge driver of decisions around whether to integrate and combine different data sources and how to do that. And then I will talk about some specific sets of approaches, including blending probability and non-probability samples, small area estimation, methods for expanding the number of variables in an analytic data set, and then also discuss some future directions. And I am going to pause at different points in the presentation, just because it is a lot of material, and just to make sure that if there are questions along the way, I can try to answer those as we go. If there are a lot of questions, I might have to defer those to the end. But let's let's see how it goes. So, first of all, to define data integration, basically what this term means is to combine disparate data sources to create a single new source that's richer and more informative than any one component. And data integration is receiving a lot of attention in the health policy space, as well as, for those of you who are joining, whose interest might be more on like the clinical side, there certainly data integration is of major interest there as well. And I'm listing some initiatives here that are certainly ones that I'm certainly interested in, and these are US based initiatives. I expect there are other countries that have similar initiatives, and that some of, for example, what's in this National Academies report applies, very generally to issues about integrating different data sources. But for example, our National Institutes of Health has an institute focused on aging that has its own data linkage program, where the goal is to help researchers who are funded for doing surveys about aging and health to be able to link those surveys to Medicare and Medicaid data, and Medicare and Medicaid are two public health programs in the United States. Medicare for persons age 65 or older or disabled, and Medicaid for usually children and also disabled persons. And we have an agency that's focused on healthcare quality called ARC for short in the United States, and they have released a social determinants of health database. And this is a database that contains measures at different geographic levels that help researchers to access these measures that are about social determinants of health at say, community levels, and that could be linked to other data sources to help facilitate health research in that area. And then we also have private providers in the US that are data brokers, such as Datavance and HealthVerity, and they aim to securely facilitate secure data linkages and health data. Linkage of health data is a huge application for those. And of course, especially for academic research, the PCORNet, this is patient-centered clinical research network. That's also a major effort in the US to facilitate linkage in terms of clinical studies and health studies and among a consortium of academic institutions. And then in the federal government in the US, there is an effort right now to explore and implement a national secure data service, with several pilot studies happening currently. And that is motivated by the 2018 Evidence Act in the US. That's the short name for legislation that was passed to help facilitate data access to support evidence-based policymaking in the federal government in the United States. And part of that has also involved basically mandates for agencies to put together evidence plans and learning agendas. And those are very helpful if you want to know sort of where the agency is going with respect to how they're thinking about their open questions and potential policies that they might be considering and need to explore first through conducting relevant analyses. And finally, I'll also mention this National Academy's report about enhancing survey programs through using multiple data sources. This is a very, very good overview of the issues at hand, especially in the context of blending federal data sources. And so I would certainly direct those of you who are interested in that to that report. And it is, certainly focused on the US, but has certainly implications more broadly. So in terms of health policy data, certainly integrating data in the US has very clear motivation if one just considers how fragmented the healthcare system is, and thus how fragmented the data are. So there are population surveys that are really important for health policy and help us understand, for example, what percentage of persons might be lacking health insurance, or might, what's the average amount people are paying for their, office visits that when they go see their primary care physician and things like that. And then these large-scale population surveys are often sponsored by governmental agencies, and there are many purposes. Could be monitoring what's happening in a particular health space, policy analysis, serving as benchmarks for efforts such as basically serving as like authoritative official statistical estimates of key health policy measures. And we have surveys. There's also, of course, electronic health records, which are governed by like health systems, and providers input data into those for the purposes of providing care to patients. And of course, claims data are used for reimbursing providers for providing healthcare, labs, prescription data, and so on. And so there's just a lot of different data sources. And one thing that's really important to note is the purpose of the data is really critical for understanding how to properly use the data, and if using the data for say a purpose for which it might not have been designed in the first place, to be able to start thinking about the implications of that. And that's where data quality considerations come in. And so I'm taking the definition of data quality from the US Federal Committee on Statistical Methodology. They put forth a data quality framework in 2020. And their definition is that data quality is the degree to which data capture useful and trustworthy information for an intended analytic purpose. And this is really key, for an intended analytic purpose. And just like you saw in the previous slide, there are all very different purposes for each of these types of data sources that are collected. And so it's really important to understand the quality of the data in the context of how it'll be used. And just a quick example of that, and I'm going to show some sort of specific illustrations of it, is that like Medicare claims data is used a lot in health policy analyses in the US. And the people who analyze that data know that data very deeply. They know a lot about the different ways in which that data were generated, and the payment systems under which that data are collected, and so on. And that becomes an important part of putting all the pieces together. And so here is the data quality framework from the FCSM report. And and here's a link to it for those of you who are interested. It's a report that you can easily access. And it's one data quality framework. There certainly are others in the survey context. I'm sure many of you who work with surveys are familiar with the total survey error framework. And this particular framework was designed because of data integration, in part because of the federal statistical systems interest and movement toward using greater use of non-survey data for, say, data integration or in other ways. And so this offers a way to assess the quality of any type of data. And so there are 3 domains you can see here that focus on utility, objectivity, and integrity. And each of those domains has several dimensions noted here. And rather than having me go through each dimension, I'm going to illustrate some of these dimensions with some examples. So I have on the slide here a data quality assessment example that highlights the objectivity domain and the dimensions of accuracy and reliability. And in this example, I would say that the data source has poor objectivity for the intended use by the data user. And so here's the scenario. So again, this goes back to social determinants of health, which are defined as non-medical conditions of people's lives that affect their overall health. And they account for a very significant portion of an individual's health outcomes, over 50%, according to the World Health Organization. And so the Medicare program is very interested in social determinants of health. And so, as part of many things they're doing on that front, they allow providers to input a special type of code into their administrative data if the provider had a discussion with a patient about their social determinants of health. And so you can see here in looking at that administrative data, regardless of which type of Medicare coverage one has, it's a very, very, very low, almost unbelievably low number of beneficiaries, Medicare beneficiaries, are having discussions with their providers about social determinants of health. And so this might seem really puzzling. Well, the reason is this measure is not used for payment. And the data from which this measure is pulled are geared primarily toward paying healthcare providers for providing care. And so it's very important to consider why does this data source exist, and what do the data elements, why are the particular data elements in the data, to help put into context what one might find. In contrast, for social determinants of health, the Medicare Current Beneficiary Survey is a large population survey of Medicare beneficiaries that includes items specifically on social determinants of health. And so that is a data source that has good relevance, accuracy, and scientific integrity, just pulling the dimensions from the data quality framework there for understanding social determinants of health. In another example, let's consider hearing loss in the United States. This is an area in which Carolina is very active in working, and is working with David Ryan, who's leading a NORC study on examining hearing loss. And in their study, they wanted to examine patterns of hearing loss in the United States, and understanding if there are demographic and geographic differences. And there certainly are important health policy implications to that with respect to understanding health disparities, raising awareness, gearing programs, aiming programs toward those most in need of those for, say, treatment and prevention. However, they encountered the issue that the data, in looking at any single data source that contains data on hearing loss, no single data source is granular enough to provide estimates at the U.S. county level and by key demographics in the county at the county level, which really limits how much to the degree to which one can understand variation in hearing loss. And so I'll return to this example later in the talk. And here's a third example from surveys. And in surveys, sometimes there's missing data or measurement error. So for example, in the Medicare Current Beneficiary Survey, and any survey really that addresses healthcare costs, that's a relatively hard to report item sometimes for survey respondents, just because it can be pretty detailed. And wouldn't it be nice if there were another data source that had healthcare costs on it that could be combined with the survey? And just to kind of, just to also say, yes, there is actually. CBS does incorporate Medicare claims into this when into their imputation approach. Another example is sometimes there's measurement error with underreporting. My colleague Mike Davern showed that in the current population survey, which is a major US benchmark survey, there's underreporting of Medicaid enrollment by respondents to the survey, and having the Medicaid administrative data allowed for them to figure that out. And then one item that's often missing from health surveys is mortality. And so oftentimes there's a desire to link in mortality data to surveys, and several surveys, such as those listed here, have incorporated that into their procedures. And the fourth and final data quality assessment example is from a Canadian example. And the goal of this study was to measure trust in public officials. And this is a study for which is an archive paper by Bahamirio and Schnitzer. And they were looking at data source, in particular, a data source that the Canadian government started to collect during the COVID-19 pandemic. And the focus of that data set was to understand the impact of the pandemic on Canadians. And so this survey was a crowdsourced web survey, and there were trust measures on the survey. So trust in public health officials in particular. And so a strength of the data was rapidly collected, and also data was compiled at the individual level. And so the data certainly have strong relevance for understanding trust in public health officials, because that is the item that is asked, and it's certainly data that was accessible and timely and punctual and had the right level of granularity to those who were using the data for policy making. But under the objectivity domain, the accuracy and reliability is really not entirely clear, because it's a crowdsourced web survey. And so on its own, it's there's no sampling frame. In other words, there's no list of everyone in the entire population. So you can't really compare, well, the respondents to those in the population, because that kind of list just doesn't exist for who might have seen the web survey invitation, et cetera. And then integrity. So, I mean, certainly, there was integrity with respect to protecting the data and confidentiality, but scientific integrity, again, is a little bit unclear, because, we don't know much about, where the respondents came from, for example, because it was a volunteer effort. In contrast, they also discussed the Canadian Labor Force Survey, which is also administered by a federal statistical agency in Canada and is a probability sample of those aged 15 and older in Canada, and also is provides individual level data. And it doesn't have the same relevance because it doesn't have the trust measures on there for examining this particular scientific question or policy question. But of course, it's accessible and it is timely data. This particular survey is collected, I believe, monthly. And because it's a population survey, the data that are provided are accurate and reliable in terms of characterizing the population. And so it lends scientific integrity and credibility to an analysis that might, combine these data. And so I'll return to return in more detail to how one might combine a probability and non-probability sample. But these are the kinds of considerations that one can make when considering different data sources and their relative strengths and limitations, and how one might want to combine the data. Okay, so before I go on, I'm going to pause and see if there are any questions about the data quality examples that I presented, or the framework. I'm also not able to see the Q&A, so
Yeah, I don't see any
Carolina.
questions. Someone raised their hand. I would ask if instead, if you could please try to use the chat, the Q&A, I mean, that would be better for now.
Okay.
I mean, so far in the Q&A, I'm not seeing anything. There was one person that raised their hand earlier, but perhaps that person can put their question in the Q&A.
Okay.
In the meantime, maybe we can continue, and then that person can put it in the Q&A. We'll break again later. Okay.
Yeah, that sounds great. Okay. So now I'm going to turn from motivation and data quality considerations to some approaches for data integration, starting with blending samples to improve their representativeness, or really improve the representativeness of estimates coming from those samples for a particular purpose. And so the first set of approaches I'll talk about are ways to combine probability and non-probability samples. And I'll focus on weighting approaches for doing this. This is certainly combining probability and non-probability samples has become a huge area of activity and research. But I'm going to focus on three particular weighting approaches that are frequently used. And these are also three approaches that are motivated by a recent data integration project that was sponsored by the National Center for Health Statistics in the United States. And so the National Center for Health Statistics collects the National Hospital Care Survey. And so this is a stratified, simple random sample of hospitals in the United States. And as part of this survey, hospitals provide encounter data, and encounter data are basically administrative data that track the procedures that are given in the course of providing care to patients and things like that. It necessarily doesn't have costs, but it tracks all the procedures. And so it's a rich data source in that there are demographics, diagnoses, length of stay, discharge status, etc. in encounter data. And So I'm going to introduce a little bit of notation. So I'm going to call this National Hospital Care Survey NHCS, and I'm going to denote it by S sub A for sample A, and there will be a sample B coming up. Let's say Y sub K is call a survey variable. Basically, you can also think about this as the variable of interest here in an analysis. So perhaps it's a variable such as a particular diagnosis. Maybe someone's maybe one is interested in the prevalence of a certain diagnosis. D sub K, A is a designed weight, and so this accounts for the sampling design for the National Hospital Care Survey at the outset. And X sub K, the set of X sub K are characteristics of, it could be the, patients who are represented in the encounters, could be hospitals, etc. But these are in the data source. And, with a probability survey, if one had 100% survey response, one could estimate the population total for Y using a Horvitz-Thompson estimator, simply by creating a sum of the Y sub K's weighted by the design weight. And here also we're going to call D sub K this basically inverse probability of being included in the sample. And I sub Ka here is just an indicator of being in the sample, and so it's just another way to write this out. So this sums over the sample elements, and then this sums over elements, in the universe. However, this survey did not have 100% response. It actually had 33.7% was the unweighted response rate. So 205 of the 608 sampled hospitals responded. And so NCHS had concerns about that response rate. There were also concerns about the granularity of the data and whether the survey alone could provide the level of detail required about certain types of estimates, such as for subgroups, perhaps by demographic characteristics, perhaps for certain diagnoses. And then NCHS also had a concern about data confidentiality, and I'll go into some detail about that in a moment. And so in short, what the concern was there is another data source that could be used to enhance the granularity of the data set, but it was not one. It was one for which NCHS had concerns about releasing that data. So to complement the National Hospital Care Survey, I'll now introduce S sub B, which is the second sample I promised I would mention. This is a non-probability sample that's actually encounter data, and it comes from a proprietary data source, and it includes, basically in short, a very large insurer, and it includes the variable of interest, Y sub K. It also includes the characteristics of interest, X sub K. So that is very important for data sets that are to be blended in this way to, in this particular application, to have these common data elements. And then there's a third data source out there that was used in the analysis called the Healthcare Cost and Utilization Project, or HCUP data. And HCUP data provide census level information about hospitals in the universe. And so this is a very important data source because it provides an anchor or a reference, if you will, for the population. And so that, I'm going to move to the next slide. HCUP was used to help adjust the design weights to create non-response adjusted weights to address the non-response, to help mitigate non-response bias by adjusting for characteristics that are in HCUP and in the National Hospital Care Survey. So you can see here these X characteristics are in HCUP. The Y variable was not, but the X's could and were used to help create some non-response adjusted weights. And then for the non-probability sample, the HCUP data were important to create what are called participation adjusted weights. And so there's no sampling frame again when data are non-probability or a convenient sample. And so what often is done is to try to align a non-probability sample with a census or a very large probability sample to basically adjust for observable differences between the two. And the key is observable differences. That is an important assumption to bear in mind. And so I'm going to go into a little bit of detail about the calculation of these adjusted weights. I'm going to focus in particular on the participation weights for the non-probability sample, the omega sub k of b. And again, the probability is there are several unknowns for a non-probability sample. There's no sampling frame. And so therefore there are unknown probabilities of selection, and therefore unknown weights that in a probability sample are used to, adjust for differences between a sample and population. And so what one has to do in this case is to estimate the probabilities of selection, these pi hats of k, using a census. And the census again provides population benchmarks that are very important for for making progress here with a non-probability sample. And so here are some steps that are used to create the participation weights. Basically, inverse propensity weighting was used. And how that was applied was to combine the non-probability sample as well as the census data. So HCUP is has also a very rich data source as well, and so it's the entire sort of data itself is available at an individual level, and so it could be combined. That's not always the case, but it was in this case, and so. In short, there's basically the probability of selection into the non-probability sample relative to the population was modeled. And one way to do that would be through a logistic regression. Certainly that type of model could be, a parametric assumption could be relaxed if one wanted to, or a different specification, but logistic regression is frequently used in this context. And then an inverse propensity weight is created based on the estimated probabilities from the selection model. And then one can create estimators. In this case, weighted Horvitz-Thompson estimator. The total would be based on using the new participation weight in the calculation. And then this is going to be an this t-hat is going to be approximately unbiased for the total of Y in the population under the correct propensity model specification. And the inverse propensity weighting approach was also applied to combine the National Hospital Care Survey sample with the HCUP data. And if you're interested in learning more about weighting approaches with non-probability data, I recommend this paper by Elliott and Valiant from 2017. That's a review paper in statistical science. And that is a good resource for learning more. So inverse propensity weighting is one approach. Another approach is dual frame estimation. And basically the idea here is when there are two sampling frames, I mean, sometimes these might be completely overlapping and sometimes they might not be, and that has to be accounted for. In the National Hospital Care Survey for samples A and B, it was deemed that A and B had full coverage, and so there weren't any issues with identifying domains that were covered by sample A, but not sample B, and vice versa. And so a composite estimator was developed to combine the estimate from frame A and frame based on samples A and B, and they were given equal weight. And so this allowed NCHS to have estimates in the National Hospital Care Survey plus the proprietary data that were more precise than just using the National Hospital Care Survey alone. And so then it enhanced sort of the informativeness of the survey data. However, the final step was that NCHS wanted to create a restricted use data set that only included the National Hospital Care Survey observations and not the proprietary database observations. And so a calibration was used to create that data set. And so what basically that meant was that the combined dual frame estimates that borrowed from both the non-probability and the probability data, and those estimates were used as essentially population totals for purposes of calibration. And so the hospital survey, National Hospital Care Survey data was estimates from that were calibrated to those coming out of the dual frame estimation. And so this allowed for creating weight that could be applied to the hospital care survey so that one could analyze the National Hospital Care Survey and have the benefit of that information from the non-probability sample, but not have the non-probability sample access. And calibration is, if you're interested in learning more about it, the canonical reference is DeVille and Sarndall from 1992. If you're interested in like a introductory sort of textbook introduction, I think Sharon Lohr's sampling textbook is excellent, not just for this topic, but for really any topic with that pertains to sampling and survey statistics. And one thing about calibration is it adjusts the original weights, but it does so in a way where the weights are constrained to be as close as possible to the original values. So it's a very, very useful procedure, and it's routinely used in survey statistics. So just to provide some details about it, I am going to just kind of focus here on this generalized regression estimator, just to kind of provide some motivation for the approach. So basically, for calibration, one has to have some auxiliary data, these X's, that are predictive of the outcome of interest, Y. And so this generalized regression estimator is equal to the Horowitz-Thompson estimator plus a regression adjusted, a regression adjustment, where beta is, or B hat, excuse me, is a regression coefficient, based on regressing, Y on X. And this T sub X is the total of, or basically population totals of characteristics X. And these are the estimates from the sample of that. So you can see if the population totals in the sample the estimated sample totals are close together, this adjustment's going to be small. If they're farther apart, then the regression estimator is going to be even more different from the Horowitz-Thompson estimator. And this can also be rewritten in terms of a weight adjustment, this G sub K. And I won't go through the details of that, but again, the references I provided will have that in there. Okay, so I am going to pause for questions about combining probability and non-probability samples to see if there are any.
There is one question from Laura Hatfield, so I can read it to you since you can see it. So
okay.
It says, these techniques require that we can individually link each unit in the probability or non-probability sample with their data in the census data set. That's the question. And that is, these methods are possible because we can find each hospital in each data set. That's the question.
Yeah, thank you, Laura. So I think for the hospital example, that's a very good question. So with the probability sample, it's important that the it isn't really linkage in the sense that as long as the probability sample hospitals are, from the population and the non-probability sample ones are from the population, that's, really key there. It is an interesting question, though, about in this case, I think that could make a difference, actually, because if you have the I don't think it's entirely necessary, but it is something that you would have to consider as part of the analysis as well.
If that's the only question so far, so we can continue
okay.
for now.
Okay, great. All right. So I'm going to just very briefly mention blending samples to explore generalizability and transportability of health policy interventions, because one, because of time, and two, because there's a lot out there in the world that of very, very good resources on this. But I do want to mention it because I'm sure it's of interest to people, and there are applications in health policy for this. Generalizability this is basically the idea of basically, do the results from a particular study apply to the greater population? And so this is an idea that came out of randomized trials because there's a concern, in clinical trials that RCT samples are not representative of the population where the the treatment might ultimately be applied. And so, it's an external validity question. So RCTs have high internal validity and possibly not great external validity. And so generalizability is an attempt to address the external validity question. And oftentimes one might hear about this, especially in like the clinical, trials world, in terms of whether RCT findings apply to a real world population or real world data. And oftentimes propensity score based methods, similar to what I just described, are used to understand the probability of, say, being in the sample versus how that compares to population. And so the propensity score methods, there could be outcome regressions, or those approaches can be combined. And I put a few references of some examples that have been applied in policy analysis contexts. And transportability is the question of whether study findings in one population are applicable to another. And for a full review, I would recommend this paper by Dedegar and Rose that appeared in the annual review of statistics and its applications and had the same title, generalizability and transportability. So just a couple examples from health policy. One example for generalizability would be if for like a new healthcare payment model or a new healthcare payment system improves patient care, and oftentimes, like in the Medicare program, there are sort of new sort of pilot projects, or if you will, that test out new ways to provide payment to providers, and they're tested using randomized controlled trials. Sometimes quasi-experimental designs are used, and even some opt-in designs. And so regardless of how the evaluation happens, the Office of the Actuary at the Medicare program has to determine for the most promising models whether to expand those models into the population. And that is a generalizability question. A transportability question might be whether health policies in one country transport to another, with the awareness that RCTs are not sort of, RCTs that are done in one country might not make sense to do those in another country, for a whole host of reasons, could be equipoise, et cetera, but there still might be questions about, whether the transportability holds. And I've put some additional pointers to the literature here in terms of blending the RCT data with real world data. There's some good review articles here that are mentioned on the slide. One thing I really want to emphasize in that space is there is a need for careful attention to assumptions because of the blending with the real world data, and because of the causal inference goals, there are some assumptions, definitely some assumptions that need to be given their due attention. And I'm not going to talk about those today, even if it's an extremely important topic. Yang and Kim have a review on blending probability and non-probability samples, mainly from the perspective of population surveys with administrative data and other non-probability sources. These they mentioned the RCT and real world data scenarios, and as she and Zahabri mentioned, the survey literature. But it's interesting because even with the connections, there haven't been a lot of like in-depth in-depth work, if you will, in terms of really doing a compare and contrast across these literatures to build bridges. But a few really, I think, valuable papers that I'll mention would be two by Keating and Lewis, who do spend a lot of put a lot of thought into the connections between these two literatures. And also, interestingly, in doing generalizability analyses with complex survey data, there are issues about how to combine propensity weights and complex survey weights from surveys. And so Ackerman and colleagues have a paper discussing that issue. All right, I'm going to pause quickly to see if there are any other questions.
I'm not seeing any questions in the Q&A right now, so I guess we can continue.
Okay, great.
Yeah.
Okay, so now I'm going to turn to small area estimation as a way to blend data to produce accurate estimates for small domains or areas. And oftentimes when a survey is conducted, especially a population survey that might be very comprehensive, and surveys also certainly have a cost involved with them. So they might be designed to, say, provide estimates at a national level, or maybe even a state level, which actually would be a very informative and sometimes granular survey. But oftentimes one wants estimates that are at an even finer level. And the sample size in surveys for maybe areas or domains of interest just might not be sufficient for that. So small area estimation techniques involve statistical modeling and pulling in additional information, and the information is used to borrow strength across domains. And so we'll show some examples of that and what that means. But basically, it's leveraging additional data sources to improve estimates for from the survey. And there are a lot of applications for disease, such as disease mapping, insurance coverage, poverty mapping, etc. And I am going to mention it was the inaugural webinar in this series that Carolina Franco gave in May 2022. It was an introduction to small area estimation. And I love the fact that this webinar series has the recorded videos on their website and on YouTube with the slide decks, and so that all the information is there. So it's a great set of resources, and please check out that webinar if you're really interested in learning more about small area estimation. I am going to talk about small area estimation. So, and this is an example, again, going back to the one I mentioned earlier, that Carolina Franco and David Ryan and colleagues are involved in. This is the hearing loss example. And because no single data source provided the level of granularity that was required for understanding patterns of hearing loss throughout the United States, they used small area estimation, and this allowed them to combine surveys with administrative records and other data sources. And so in particular, they produced estimates of of bilateral hearing loss by county for 48 groups defined by demographic characteristics. And they combined several data sources, but two key survey data sources were the NHANES, which is the National Health and Nutrition Examination Survey, and the American Community Survey. And the American Community Survey is a very large probability survey in the US that asks about hearing loss as a binary measure. Has a larger sample size than NHANES. On the other hand, NHANES has many health measurements that are taken by trained technicians. And so the hearing loss measures in NHANES are at a finer level of detail than in the ACS. And so the ACS was pulled in to this analysis to help provide some additional precision for estimation. And this is an example of the map they came up with to show the percentage of any hearing loss by county in the United States. And as you can see, there's a lot of variation, including important patterns, especially in rural areas. That was one of the findings they had, was higher percentage of hearing loss in rural areas. There are also older populations in rural areas, so there's a correlation there. But it definitely helps one think about where one might want to focus efforts on, like prevention and treatment. And if you're interested in seeing the full scope of their estimates, they have a wonderful website called soundcheckmap.org that provides an interactive display of these hearing loss estimates. And so for small area estimation, there are several modeling choices one can make. One could model at what's called the domain level. So the Fay-Harriott model is the canonical model for those analyses, and I'll describe what that is momentarily. Basically, in short, what that is to basically have observations in the observations in the analytic data set are at the domain level. And there's also unit level models, which also one might think of those as hierarchical models, where if it's a matter of hospitals as observations versus patients as observations, that's the difference to illustrate the difference between a domain versus a unit level model. There are different ways of adding additional external or auxiliary information in small area estimation, adding it into the analysis. It could be through adding domain level covariates, or it could be through multivariate modeling. And there are, Bayesian and non-Bayesian. One can be a Bayesian or not be a Bayesian. It doesn't really matter. There is a whole host of applications out there. I mean, there certainly are pros and cons, strengths and limitations to various approaches. I don't want to be, glib about it, but there are a variety of approaches out there that have been used for fitting these types of models, and of course, different distributional assumptions that one can make in specifying the models. And so here's the classic model, the Fay-Harriott model. This is a domain level model where yi is a domain level observation, like a county level disease rate, for example, and yi it equals theta I, which is the true but unknown value of interest in population, plus an error term E sub I, which in this case we'll just go with the linear model for ease of explanation. Oftentimes these error terms are assumed known, so the domain estimate might be based on some, say, like a large survey or some summary information for a domain. And then in turn, the theta I is then modeled as a function of X. So here we have a regression for it where the auxiliary data are linked to the underlying true value, and the UIs are random domain effects. And then a predictor results, which blends YI, the direct estimate, with the modeled component, in this case, since it is a hierarchical model structure, I'll call it a shrinkage target. And then the weighting happens according to this gamma I term, which will be very familiar to those of you who are familiar with two-stage hierarchical models. And so basically, if YI is a very precise estimate, this predictor will be closer to YI, relatively close to YI. If YI is not very precise, then this predictor will weight the auxiliary, the shrinkage target component more heavily. I think in the interest of time, I'm going to skip this slide, and it'll certainly be available in the slide deck that's posted. I will also show, I mentioned the bivariate small area estimation approach, where one might not add in auxiliary data as covariates, but let's take this example of health insurance coverage in a state. So that's the variable of interest, and the National Health Insurance Survey in the United States provides an estimate of insurance coverage, and it's regarded to be a preferred estimate relative to other data sources, but we also have an estimate from the American Community Survey. And so, Franco and Bell and Franco and Mitra looked at this example and fit a bivariate outcome model, also had random state effects, and also, similar sort of sampling error. In a bivariate case, these data sources are, in this case, these estimates are regarded from these different data sources to be independent. And here is really the benefit illustrated, as this shows the estimates. So if the unmodeled or direct estimate and the direct estimates were the same, they would fall along this red line. This is sample size on the x-axis. And so the direct estimates there is variability, especially at lower sample sizes for states, but as the sample sizes become larger, these estimates do become closer together. And very importantly, the variance estimates, the direct estimator has a variance that's, in this case, over 4 times as large as under the bivariate modeling approach. And certainly with sample size, this levels off. But for small sample sizes, this is really a major motivator of using small area estimation. And there is a bias variance trade-off with small area estimation, as you can see here, it's really about overall mean squared error reduction. So I think I am going to pause and skip this example simply because of time. But before I continue, I'm going to pause and see if there are any questions.
There are a couple of questions. So one is from Jessica Rapson, who asked, do methods that use propensity score matching consider how propensity matching can increase data unbalance?
Yes. So data, right, the balance issue is is important. And so there are a couple, I guess, a couple of things to say on that. So in the generalizability and transportability analyses, that's something, if you look at applications, focused on those topics, there's a lot of attention to that. In fact, there are, assumptions, specific assumptions that you have to make that, the characteristics that are used for, say, predicting the probability of being in the sample, or being in a population or what have you, that those characteristics, that the same set, the same sort of types of characteristics are in both, like the population and the sample, that there, and so there are considerations like that. And there are, just more generally, there are diagnostics that one can use to examine, things such as the covariate distributions, and also even looking at the distribution of the estimated propensities can be really important. And so if you want to, say, compare two samples that, their propensities are kind of like this, then you really are in trouble. But, you want to have some overlap, because you want to identify where there is overlap.
Great. And there is another question.
Okay.
So it says, do you know of any work on SAE techniques when the adjacency matrix is more complicated than spatial? For example, borrowing strength across different network structure, like a social network.
Oh, that's interesting. I don't know offhand. I don't know, Carolina, if you know. But
it's a
nothing,
really interesting question.
yeah,
I haven't seen anything.
Yeah.
It doesn't, I mean, if it exists, it's very innovative. This is from Laura. Laura Hatfield. Laura, perhaps we should chat more later with Susan.
Oh, yes.
Right. This is a really interesting question.
Yeah, absolutely. Absolutely. Yeah, especially with networks, because they can be so, like, I mean, it's just a very challenging data structure. All right, I am going to talk about methods to expand the number of variables in a data set. And I am mindful we have 15 minutes left, and I'm going to keep my, I'm going to keep sort of my, I'm going to keep my, I'm going to keep to the next, say 10 more minutes, and allow 5 minutes at the end for Carolina and Damaris to make their announcement. So in brief, one can link data or match data, or statistically match data, to be precise. And so in terms of record linkage, one question is whether data sets have overlapping variables. And if they do, the next question is, are the units or entities or subjects in the data expected to be in both data sets? And if the answer is yes, then we're looking at a record linkage scenario. And then the question is really about how clear the and consistent the identifiers are for the entities in the data. So by entity, I basically mean the subject of interest. So if it's a question about matching, linking data sets, that have the same hospitals, and you're expecting all the hospitals to, be in, like, you have a data set with, say 300 hospitals, and you expect those 300 hospitals to be in another data set, and you want to have a full record of each hospital, then that is a linkage scenario. And if you have identifiers that are sort of clear, like name and some kind of social security number in the US or equivalent in other country, then a deterministic linkage might be appropriate. Or if there's some uncertainty about it, probabilistic linkage procedures would be appropriate in that case. And the scenario with record linkage, again, is we have some Ys and some X's on file 1. We have some X's, and I made them X asterisks in file 2 with some Z's, and perhaps one wants to link file 1 and file 2 because they want to know for each record what, something about, combining Y and Z. Possibly X could be of interest too. X and X star might be equal, or they might not be. They might, and they could be direct or indirect identifiers. And by indirect, I mean, measures that are not name, social security number, things like that. And here's another reference to another webinar in this series. Just last in May, this May, Natalie Shlomo gave a webinar on record linkage. And so I'm, not going to say a whole lot about record linkage, given her webinar is available and it was very recent. And also in interest of time. So I think what I'm going to do is just note that the Filigi Center framework is the, canonical framework for probabilistic linkage that you will see most often. And I'm not going to go through the detail, but I'm going to leave it here. And there's also the other webinar that you could see. But basically, in short, there's a way to interpret, the formula as in terms of a Bayesian probability of probabilities of matches or non-matches given a comparison vector between two records that might be possible matches. I do want to just touch on some there's been a lot of also extensions of the Filigi Center framework that are listed in or discussed in this reference by Bennett and Sturtz from 2023. I do want to mention additional considerations. Sometimes data are linked and users will use the linked data without really any way to access what the uncertainty was in generating the links. And so there are joint Bayesian modeling approaches one could use. I'd say this is certainly an area of current and future development in terms of taking that idea and translating it to like data use and data users more broadly. Data quality considerations are important with respect to measurement error for linkage, and there could be health equity issues with respect to data quality for underrepresented groups. Jana Asher and colleagues have a paper on that. Obtaining consent from survey respondents is a very hot topic now because of the push to augment surveys with administrative data and other data sources. I think the lessons are still being learned in that growing literature. Privacy and confidentiality is a huge area of activity and concern and interest because the more data that are linked for a given individual, the higher the risk in terms of data disclosure. And so there's work being done about, with respect to linkage and privacy protected record linkage or synthesizing sensitive data elements to reduce the risk of disclosure. And also validating linkage results is something that users might want to consider as well. And this is a document by Doucette Zina and colleagues that has some suggestions for how one might do that. And then the other approach for increasing variables in a data set is statistical matching or data fusion. And this is a scenario in which there's interest in the joint distribution, but not necessarily in linking particular records in one data set to the other. It's really about the joint distribution. And as you can imagine here, with the missing data elements shown in sample A here and sample B here. So in B, you don't get Y, but you get X and Z. In sample A, you get X and Y, but you don't get Z. There are identification assumptions that are required in order to identify the joint distribution. And D'Orazio et al. Have a introductory textbook on the topic. And I think that's one key message I would say about statistical matching is there are certainly, I think in particular, the assumptions become very key and important. And one example I'll briefly point out that I think is an interesting example in the health policy space about statistical matching is looking at long-term effects of health policy interventions. So the Oregon Health Insurance Experiment, the results were published in 2013, and it was a lottery to provide subsidized health insurance. And people who were randomized to be eligible to obtain subsidized health insurance had improved health outcomes by the end of that study. And we're going to call those short-term outcomes. And the policy challenge addressed in this paper by Michael Robbins and colleagues, it's an archive paper, was what are the long-term outcomes of this insurance experiment? So they statistically matched National Longitudinal Mortality Study, which had 11 years of follow-up data on mortality relative to the first OHIE follow-up, and they found that the lottery winner's mortality was still significantly lower, even 11 years after that experiment. They had to invoke some assumptions, and one was that the intervention effect is explained entirely through the intermediate variables, which are those common X variables common to both data sets. And they also had to assume that the conditional distribution of the long-term outcome, given those intermediate variables, was the same in the long-term data versus the shorter-term data. And you might guess by the use of the term surrogate validity, there are connections to clinical trials literature in terms of surrogate markers, which are intermediate outcomes that are proxying oftentimes for longer-term outcomes. And so a very interesting analysis and application, I would say, in health policy, and we might, perhaps see more of that, especially thinking about, Susan Athey and colleagues who had a paper looking at a surrogate index to try to address the same objective, but in a different way. And they had essentially two identical identifying assumptions as well in their analysis. So I realize I'm out of time. And so I think what I'd like to do is just put the future directions slide up here and take a question if there's a moment available for a question, Carolina.
Yeah, I'm not seeing any questions right now. So maybe if there are any questions, this is your last chance. Just put them in the Q&A. If not, we'll do some announcements. We have some important announcements to do. Okay. Well, in the meantime, let me do some announcements, and then if there are any questions, you can put them in the Q&A. Okay.
Okay.
So so one announcement is just a reminder that in the past few years, the ASA has decided to lower the membership fee for developing countries to $10. So I'd encourage you to check it out. I think Alex already put something in the chat about it. I also want to announce our our next webinar. I'm gonna share my screen really quick, Susan. I think you might lose yours for a second.
Okay, let me
see.
stop and share. There we go.
So the next webinar will be on September 25, same usual time, the same time as today. And the presenter will be Claire Bowen, and it will be on data privacy. So it'll be extremely interesting. I don't know if you can, I don't think you can see it yet. Can you see it now? So you can check this out in our website. So that will be the next webinar. The other thing I wanted to announce is, I made a short announcement last time, but we have this very interesting special issue coming up for the Journal of Survey Statistics and Methodology. It's focusing on survey research from Asia, Pacific, Africa, the Middle East, Latin America, and the Caribbean. And it will be a very interesting special issue. It will feature interesting contributions to survey research in these areas of the world that may have not received enough attention in the past in surveys like the Journal of Survey Statistics and Methodology. And it will be free to read, which means that it will be freely available to readers at no additional cost to the authors. So that's quite exciting. And I announced it last time, but I wanted to let you know that we extended the deadline. So currently the deadline is on September 30th. The same announcement is on the CIRS website. So anyway, if you have any questions about it, you can contact me. I'm leading the special issue, and here's my email address. So I look forward to getting some submissions on this. So the last announcement is from our representative from Statistics Without Borders. So I'm gonna stop sharing. Damaris, you wanna tell us your announcement?
Yes. Hi, everyone. My name is Damaris, and I'm here on behalf of Statistics Without Borders. So let me just share my screen, and then for just a minute, I talk about Statistics Without Borders. I hope I'm visible. Yeah, so Statistics Without Borders offers pro bono services in data science. We are a global volunteer outreach group of the American Statistical Foundation, and we envision a world where communities are empowered with the statistical and related expertise so that they can make evidence-based decisions. Personally, I joined Statistics Without Borders in December 2023 as a delivery and quality assurance specialist. So my role involves going through project tasks and ensuring that they abide by the guidelines as stipulated by the organization. So other roles in the organization include being a project client manager. This is somebody who coordinates the volunteers and oversees how they are going to conduct the tasks. We also have project volunteers. Now, these are the people who lend their technical expertise to the organization. And then you also have statistical consultants. They are the people who are more experienced, and they are responsible for offering their expertise. Some of the projects that Statistics Without Borders has contributed to include UNICEF in Sierra Leone, Asante Africa Foundation in Kenya and Tanzania, Save the Children in Ethiopia, Haitian earthquake data collection. And some of our partners include one I initially mentioned, which is the American Statistical Foundation, American Association of Data Advancement in Science, and DataKind. So to seek volunteering services with SWB, all you have to do is log on to the website under the tab Clients, and then you can request request SWB assistance, and then you'll fill the form. And to join the organization as a volunteer, there is also a link for that where you provide details, and then once you become a member, you'll be receiving emails about projects and updates about the organization. So to follow more about what we are doing on social media, you can log on to our websites, but we are also available on LinkedIn, X, and YouTube. I think that's all. Yeah, I'll provide the links. I'll provide the links at the end, in the chat box section. That's all. Thank you.
Thank you very much, Damaris. Okay, well, since we're a little bit over time, I'd like to take a moment to thank Susan so much for a fantastic talk. It was really interesting. There's lots of thank you in the chat too from people. And I think perhaps we should close it here, given that we're a little bit over time. If that's okay with everyone, we're gonna close it here. But thanks again, Susan, and thank you everyone for coming, and thank you, Donna, Alex, Damaris for organizing this with us. And so, I mean, there is one last question about the bibliography, but we can probably we can put that in the website. I think the bibliography that we mentioned, right, Susan?
Yes. And that will, I think, be very highly correlated with the paper. So
yeah, so probably the best thing to do is just to like read the paper, but we'll try to, or you can contact me if you'd like, and we can get the bibliography to you.
Yeah, and okay, there are a few references I think I added in that are not in the paper, so I can kind of call those out as well, so that so I'll do that before I send you my final slide deck. But thank you very, very much. This has been great. Thank you.
Okay, well, thank you, everyone.
Very nice talk.
Thank you, everyone.
Bye.
Thank you.
See
Bye-bye.
See you in the next one.
See you in September. Take care.
Bye-bye.